Franz Gall, a German neuroanatomist and physiologist, proposed the concept of phrenology. Many of us laugh at this today, but this was really the first attempt to assume that brain function is in the parenchyma of the brain, not in the spinal fluid. And this was the first attempt. Now, Franz Gall believed that because your bones fuse after birth and your brain function certainly developed before that the folds of the skull then would identify different personality traits. And this is what phrenology is. But we mock this today, but really it was the first time that anyone even proposed that the parenchyma, not the spinal fluid, was where thought processes occurred and how the brain communicated with the peripheral nervous system. And that was a unique idea. Now, this gentleman is a French physiologist, Jean Flourens. He's a pioneer in anesthesia. He actually was a staunch critic of phrenology, and so he set about attempting to prove Gall wrong by ablating different parts of the nervous system to prove that phrenology was incorrect. By doing this, he proved himself wrong too, but did start demonstrating some of the methods by which we developed an understanding of nervous system localization over time. So he started by ablating peripheral nerves, medulla, quadrigeminal protuberance. These were all in animal studies, cerebellum, cerebral cortex, and observed and recorded the outcomes. Because the vertebrate animals didn't have a lot of higher executive functions, he didn't go very far with understanding things beyond motor and sensory function, but did start the process. We're going to skip 2 centuries now, just because of our limitations on time. But through observation, a lot of times through patients who had ischemic strokes, especially out of France and England, a lot of understanding of you would have a patient have a stroke, you would do a thorough neurologic exam, and when they passed away, then they would get anatomic dissection of their brains, see where the infarct happened, and then getting a series of patients over time, you would then, with a similar infarct and neurologic exam, you would then slowly develop an understanding of brain localization. This then comes to Harvey Cushing, really the father of American neurosurgery. Between 1902 and 1912, he was at Johns Hopkins Hospital, and he expanded mapping of the human motor cortex using Faraday stimulation. And he completed motor mapping on 41 anesthetized human patients with epilepsy, tumor, or trauma. And between 1908 and 1909, he also reported stimulation in awake patients that included sensory and motor mapping. He wanted to really focus on transsphenoidal surgery for cellular tumors, and passed a lot of this work on to his protege, which we'll get into in a minute. But already in 1910, you can see this personal drawing from the operating theater by Cushing, where he's mapped out the motor homunculus, the sensory homunculus, hearing, vision, and some rudimentary speech pathways from monopolar cortical stimulation mapping in awake patients as early as 1910. And he never published these data, but was found in his personal archives later. But an apprentice to Cushing, Wilder Penfield, who founded the Montreal Neurological Institute after training with Cushing, he expanded our understanding of motor and sensory distributions using cortical stimulation in awake patients. And in 1928, working with Ottfried Förster, he reported on motor and sensory homunculi based on 126 patients. This was really the predecessor of the Van Wagenen Fellowship, because Förster also trained Van Wagenen on an international fellowship paid for by Cushing himself. So I even trace some of my training and lineage to these origins. This is a publication that came out later from in the late 50s by Penfield and Lamar Roberts, reviewing language manipulation and cortical stimulation in awake patients for epilepsy surgery. This describes their first 110 patients, recording 132 aphasic-like errors across the temporal and frontal regions of the brain. It reinforced that pathologically determined language areas that were described a century before based on these patients with infarcts or other neurologic disorders, tumors, etc. But also broaden the understanding of what was previously called the right or silent hemisphere as not being so silent, just involved in different functions that couldn't be tested historically. As you see there on the left, where space orientation is noted in the region that on the left side would be speech. This developed into a greater understanding of the white matter pathways that we understand are involved in speech today, as well as now the much more complex visualization of the subcortical pathways with connectivity maps from MRI especially, showing the complexity of the speech system in humans. But let's get back to then brain localization in tumors and why it's useful to perform cortical and subcortical mapping in the brain. In the United States, there are approximately 20,000 new cases of primary brain and CNS tumors annually in the United States, over 12,000 deaths. Most common types of these tumors are diffuse gliomas, and they tend to surround brain parenchyma, including eloquent brain, and invade it and recur after initial treatment. And there's increasing evidence regarding the value of extensive tumor resection to improve survival and quality of life for these patients. A lot of focus has been aimed at surgical techniques to improve extent of resection, but at the same time minimize morbidity. This is known as maximal safe resection. Methods include functional neuroimaging that can be done preoperatively or intraoperatively, evoked potentials electrocorticography to monitor for seizure activity, intraoperative MRI or ultrasound imaging, intraoperative cortical and subcortical electrostimulation mapping. And I think it's important when we think of preoperative imaging with functional MRI, functional imaging can be obscured by T2 abnormalities. And also, brain shift occurs at surgery, making those preoperative images less valuable from a navigation standpoint over time. So they're less useful in the surgery itself and more useful for surgical planning. Motor evoked potential or phase reversal recording also only identifies an intact pyramidal system or the location of the central sulcus, but does not offer direct information on distribution of motor function on adjacent exposed cortex. Intraoperative imaging can help alleviate the brain shift problem, but doesn't give real-time functional information. In the case of intraoperative MRI, are expensive and time-consuming, but direct cortical and subcortical stimulation. It's also somewhat limited to really what can be tested in a few seconds of stimulation, and can cause seizures if we're not careful, and that can obviously cause issues at surgery. Patients emotionally or psychologically can have challenges to awake surgery and anesthesia, but it does really afford the most sensitive and specific modality of direct testing of these eloquent brain areas for glioma resection, especially regarding speech and vision pathways. Here's an example, just quickly. A woman who presented with a generalized tonic-clonic seizure, had a postictal mixed aphasia and right hemiparesis that recovered over a 24-hour period. She had this lesion, which is just shown here on the right, with a left temporal and insular T2 hyperintense mass consistent with a low-grade glioma. This was not enhancing with contrast. This is a T1 sequence functional MRI, and you can see in this case that you can see that there's some speech activation anteriorly in the frontal operculum, but the tumor itself is essentially a black box that the bold signal doesn't really pick up through the middle of the glioma. And it's true, white matter pathways with functional diffusion tensor imaging can give you a little more information, but even then, as you can see, the superior longitudinal fasciculus loses some of its representation through the lesion. And that's true of the inferior longitudinal fasciculus as well. So intraoperative cortical and subcortical stimulation with electrocorticography was performed in this patient. I typically use, for electrocorticography, a strip electrode to avoid obstructing your view of the cortex, looking for after discharges to make sure that you're not putting the patient at increased risk of an intraoperative seizure event because of the stimulation. Bipolar stimulation, typically I stimulate between 2 and 6 milliamps of bipolar stimulation at 500 microseconds and at 50 hertz. Typically you've reached threshold on the cortex between 3 and 4 milliamps. Use of various language testing paradigms during stimulation by either speech therapy or neuropsychology. It's important to not stimulate the same place twice in a row with at least a break of 10 seconds or more, or you'll increase the risk of seizure because of compounding. And a recent review of our department's cases showed an intraoperative seizure risk around 1.5%, which is consistent with the literature. Studies have shown it's safe to resect tissue up to 5 millimeters from the region of positive stimulation response. And this is just an example. In this patient, where the numbers on the screen there, you can see 2 is superior temporal gyrus, and that was creating errors with stimulation. 1 produced tongue fasciculations consistent with motor tongue, and 3 induced speech arrest. She ultimately had partial resection with a seizure intraoperatively that resulted in, it was just a partial seizure. She did not require intubation, but had postictal paraphasic errors requiring aborting the procedure early. We got about 50% of the tumor out, as you can see here. So most of the temporal lobe was removed anteriorly, but and some of the insula, but significant tumor remained. And she came back with a grade 2 oligodendroglioma. She actually elected to go to chemoradiation and didn't want to go through another awake surgery, although was offered this, which is a reasonable approach in this setting. But we probably could have resected some additional tumor if we had had the opportunity to go back for another resection. This is another case, although we're out of time, but just showing that it's also useful in motor areas, stimulation. And this is in a sleep patient with stimulation mapping, where we found identified the motor homunculus, which you can see here. And this is the premotor area where the tumor is, and he got a gross total resection of this recurrent high-grade glioma. And intraoperative mapping has dramatically changed glioma surgery with a significant increase in surgical indications in eloquent areas previously considered inoperable. In the setting of low-grade glioma, 98% of patients recover at least to their preoperative status, 15 to 20% of patients improve function, 80% have an improvement in seizure frequency, and life expectancy increases significantly, which is much better than resection without mapping, where 13 to 27.5% show new neurologic deficit and a lower extent of resection than when you use mapping. In conclusion, significant changes to our understanding of brain localization over the past 2 centuries have really made maximal safe resection of gliomas possible, improving survival and quality of life for patients. And intraoperative mapping with epileptology, neuropsychology, speech therapy, and functional imaging can improve extent of resection while preserving or improving quality of life. Thank you very much.
Yes, thank you very much, Professor Ryan, for the presentation. And like we had initially agreed, we are going to have a question and answer session at this point for the first 2 presentations. And thereafter, we shall have the third presentation, which will be coming in from Mbarara Regional Referral Hospital. And for the online viewers, especially those on Zoom, then those on Zoom, then and YouTube for live streaming, then we proceed. I don't know which computer we are going to use for that. Maybe you can use. Yes, after he's around. Before I wanted him to first connect so that when he's giving the presentation it is already live. Okay. Yes.
For the next lecture. I can connect to Zoom. This is fine.
Yeah, in the meantime, I want to recognize the new members that have joined us. I can see Dr. Mbusa Amos Kasova, who is a fellow in the Division of Neurosurgery, Mbarara University. Please, you can stand up for recognition. I've also seen one of the freshest graduates from Makerere University, Ntege Moses Paul, who graduated yesterday with a master's degree in neurosurgery. You're welcome. So you will bear with us for a few minutes as the people in charge of technology connects in the interest of the online viewers, and then we shall have the next presentation on the agenda. And for those, we have a few people who deal within the drug market at the end, at the left corner. I think with time we shall pass by and see whatever they have at display for us for today's session and moving forward. Yeah, so in the meantime, allow me introduce our next presenter, who happens to have done his high school at Uganda Matters Secondary School, Namugongo, where I and Dr. Mbusa happened to have gone. He also did his undergraduate training at Mbarara University of Science and Technology. He did his postgraduate training in pathology at Mbarara University of Science and Technology, and has been there for a number of years as a lecturer, currently head of department of pathology, lecturer at KIU. We shall welcome Dr. Atune Raymond for the next presentation. Ladies and gentlemen, let's welcome Dr. Atune Raymond for the histopathological diagnostic pathways for brain lesions at Mbarara Regional Referral Hospital, Mbarara University.
Yeah, thank you very much for the introduction. It was very precise to the point. I will not repeat that. I'm called Raymond Atone. I'm a pathologist at Mbarara Regional Referral Hospital, stroke Mbarara University of Science and Technology. And I've come to give a broad overview about the neuropathology services that we give at the hospital. And of course this is going to be brief, and generally an overview of what we provide. The is face, which may be similar for other low to middle income country pathology departments in that case. So the outline is going to be still brief, looking at the overview of neuropathology services at MUST, the workflow of neuropathology samples, the diagnostic capacity, and of course challenges, as well as a few things on what we can do to improve the service. Pathology department as a whole is of course a core diagnostic hub, not only for the hospital but for the whole of southwestern Uganda, and actually even beyond southwestern Uganda, including surrounding countries of Congo, Rwanda, and Burundi as well. And of course, we offer a wide variety of services, including histopathology, which neuropathology may be probably most interested in, cytopathology, autopsy services, as well as basic IHC services. Annually, we get about 7,000 surgical specimens. Pathology specimens are part of them. About 3,000 cytology specimens, of which CSF specimens are part of them. We've got a few specimens of CSF, especially from pediatric patients for staging as well. And currently, about 4,000 IHCs are run on a manual basis, and we perform about 600 autopsies. So literally a very big workload there for the department. So of course, like the previous presenter has probably hinted on, there is going to be an increase. There's been an increase in the neuropathology lesions over the past few decades. I think most of the increments are happening in the Europe and USA environments, and a few of the increments, or relatively lower increments, are being seen in Africa and low to middle income countries, I think probably because of underreporting of diagnosis. And over the past few years, as pathology department, I've seen an increment in the cases coming from neurosurgery. I think previously we used to get about 20 cases per year. Currently, we get about 50 to 60 cases every year, which is a big increment. They look small, but that's a very significant number. Considering the resources or the environments that we live in. So this is literally an overview of the workflow of these samples that come from neurosurgery. And of course, as usual, we receive specimens and record them and give them a unique identifier or unique lab number. Then of course we gross examine them, and grossing is very important, or gross examination is very important because it can give us a lot of things that can help us to come up with a diagnosis. For example, if you find a lesion that is black, you may probably suspect that it's likely metastatic melanoma, which will give you, of course, which will tell you what extra tests you need to run later on. Usually gliomas are gray-white, a little bit solid, but of course most of the samples that we get grossly are usually multiple fragments of tissue. Of course, very rubbery in most cases. If they have been fixed enough, they're a bit hard, but most of them are soft. But you know, a lot of information is going to be got from grossing. Yellow may probably mean that you know there's a necrosis, a little bit of brownish, probably there's hemorrhage, and very many things that grossing that can actually help us to come up with a diagnosis at the end of it all. Then, of course, we take them for tissue processing, as well as doing routine H&E, hematoxin and eosin, and then we put them under light microscopy where we come up with a morphological diagnosis. And of course, I'll sign out reports. But in rare cases, or in a few cases, we shall really be able to do special stains, especially for infectious organisms such as Gomorrah methamine stain or periodic acid sheaf, but also definitely IHCs, which really are very, very vital in confirming these diagnoses. Currently, our turnaround time for most of the specimens, including neurosurgical specimens, about 10 days. Averagely, Usually range is about 1 to 2 weeks in that case, and this one has improved over time. Initially samples you take actually 2 months, 6 months, but that has really greatly improved as well. And of course, when we make a diagnosis, sometimes we may need a second opinion, and colleagues from institutions we collaborate with, one of which is MGH. They are very good. There are very many neuropathologists at MGH that we can send images of these samples that need second opinion of. We have also had prior collaboration with University of Wisconsin in Madison, but the neuropathologists at that institution retired, so probably not as very active as they used to be in that case. And of course, in some cases, we may need to refine these diagnoses by doing the neurosurgical pathology conferences, which we have done previously before with success. Of course, currently, most of the pathologists that the referral are general pathologists, general anatomic surgical pathologists, and of course, being helped by lab technologists as well as mortuary technicians. And currently, we have about 9 MMed pathology residents who help us a lot in organizing for these new pathological conferences. And of course, one of the biggest gaps that we see, not only in Uganda but in low-to-income countries, is that we have really very few trained neuropathologists. And what we have realized with the capacity we have is that at least we have got a relatively good experience to make really very comfortable diagnosis in CNS tumor pathology as well as other organ pathologies. Of course, the lab is fully functional. There are very few labs in low to middle income countries that IHC services, because most of these IHC services are very expensive and not easy to come by. But we're lucky that we can do part of that. Of course, there are things that we're doing this free of charge. Patients bring in their samples done free of charge. Even currently, the IHCs are done free of charge. For the institutions, pathology institutions that have IHCs, those ones are being paid for by the patients. But for us, we are trying to use the little we have to pay for any service that they get from us. And of course, we have a unique disease spectrum that is different from the one that you see in Europe and America, especially when you look at the HIV-associated lesions, which you may not find a lot in Europe. Those are very common here, which is unique in our setting. Of course, the IHC panel is definitely limited. We get it from well-wishers who are able to support that, Ministry of Health support that, as Ministry of Education. No molecular pathology, of course, that's a very big challenge, which is, I think, a uniform problem in low to middle income countries. And of course, because of that, we may not be able to fully align with the current WHO CNS tumor classifications. And we think in the future, samples may probably need to increase. We get about 50 to 60 samples every year, but I think those may probably not be very sufficient if you have very many students you are training, or if you want to do very big researches. So I think we may probably need to see how we can get in more neurosurgical samples to the lab. I'll not go so much on this, but of course, some of the gaps that we face is that if you look at people centers that are well resourced, they are using IHC stainers, which of course standardize the work and make the work much easier for us with manual setup, which is a bit hectic, and of course prone to very many challenges as well. We have a slide scanner, which of course has helped us to be able to communicate and send images for second opinion or take images for neuropathology conferences, but that scanner of course breaks down very many times, limiting telepathology services. Molecular platforms still not there, which is a very big problem, especially when you want to be able to align with the current WHO CNS tumor classifications. Frozen sections are very important, I think this is a routine in well-resourced countries. Frozen sections help us to really determine the nature of lesions intraoperatively. For example, if you have, it can tell you the different, if it can tell you whether it's a low grade, high grade, and of course, the previous presenter was talking about resectability, and of course that may determine the resectability operatively. If you are looking at, for example, lymphoma, and which probably may not need surgery. In that case, if you did probably reduce the resectability of lymphomas in low to middle income settings as well. And of course, also doing other things such as differentiating between plastic and anaplastic lesions, which of course may definitely guide your decisions intraoperatively. So IHCs are very important in confirming this diagnosis, and are very important in trying to be able to align with some of the with the current WHO guidelines of reporting of CNS tumors. And in the lab currently we have a few, and most of them are not specific, such as GFAP, which is really very broad. Chi-STEC7, not as broad, but still very broad. Cyanoptophysin and chromogranin, those are neuromarkers, still broad, so they may not really help you to come up with a one as well. And even with these ones, currently we are having a few mix of them, or very little quantity. Or if we don't get further support, these may actually not be there in the coming few months. Of course, the ones, at least the ones that we can start with in our resource limited setting, GFAP, of course, we have talked about it. OLIG2 for oligodendrogliomas, we have MA for meningiomas and epidermomas. Cyanoptophysin, I've already talked about it for the neuro ones, such as neurocytomas, medulloblastomas, and even the pitnets may definitely be positive for that. Cytokeratins, especially for metastatic carcinomas, and that may further be subtyped with things like TTF1 for the lung, GATA3 for the breast, PAX8 for malaria and kidney or thyroid, CD45 for lymphomas as well, sulfur for germ cell tumors. Then the pitnets, we don't have the transcription factors. Ideally, you are supposed to supplement this with pituitary hormones, but that definitely in our setting because of the lack of that. And of course, melanin, melanoma, metastatic melanoma, which is not very uncommon in the breast, as well as the Chi-STEC7, which will, is very important for the proliferation. Of course, with IHC, in absence of molecular, you can use some IHC. You can use some IHC antibodies as molecular surrogates, such as the IDH1, IDH mutations. You can do IDH1 around 3,2 HIHC as a surrogate for IDH1, IDH2 mutations. Then you can do ATRX-IHC for the ATRX inactivation mutations, very important in astrocytomas. Then you can also do the IHC, P53 IHC for the P53 mutations. And those ones, ideally do them, but of course we don't have the antibodies. So the missing link here is the molecular gene, which we don't have currently. And I think as maybe people will allude to, this is very important for the current CNS tumor classifications. And for us familiar with morphology and IHC, sometimes that may not give you the pinpoint diagnosis that you may need to make, and that may definitely alter the management of the patient in that case. So because we don't have the molecular diagnostics in our department, of course that may bring about incomplete tumor classification, limited prognostication, and of course challenges in guiding therapy. Because some of these therapies are targeted therapies that are going to be arising from these mutations. So our main challenges, of course, we have limited supplies and consumables. The university and hospital try to give us a few of them, but with the numbers that we have, really they are really outcompeted in that case. And for the antibodies, that's really a gray area or a dark area. where really we get these from just well-wishers and of course donors that send us these. These are definitely don't have a budget in the hospital, a budget in the university, so it is really an area where we really need to get support from in case it was available. And of course that one causes frequent stockouts, which affects the service continuity. And of course donations. Without donations, some of these things definitely are going to be challenging to be done as well. Still IHC, at least this one we can do. We have the capacity to do that. The only things that we miss are the reagents or the markers. We have very few markers, really, like I told you before, usually from donors and well-wishers and collaborators, and usually there are no structured budgets in Ministry of Health or even in Ministry of Education for IHC. So that is still really a very big challenge in most of the low to middle income countries. Even for those who have them, patients usually pay for them. That it's a bit more sustainable in that case. We have an issue of sample referral and loss of numbers, case numbers. And we have realized that, of course, some of the samples are shipped to private labs. And the driver for this is that one of the drivers for this is IHC. Maybe they want to do IHCs that we don't have, or they want to do molecular diagnostics that we don't have currently in that case. But of course, we have also seen cases where samples are divided or samples are taken away for primary diagnosis, which of course leads to the reduced numbers at the lab. Yet we need these numbers for teaching, for the fellow that is currently going on, and for the MMed neurosurgery that is starting soon. And of course, because of that, we also have really missed chances for training and research opportunities. Samples really are very, very key in research. So, of course, with these sufficient samples, you are able to be able to train the neurosurgery residents, the pathology residents, as well as the medical residents. And of course, the tumor boards that we used to have, or that we currently have, would be more regular if you had this in play. And of course, research projects would be much more, which would actually increase in number. And of course, even other collaborators may hamper the research that would be going on. Of course, with enough support, definitely would want to be a center of excellence in pathology, and of course, improve our turnaround time to probably less than a week. I know in the US it's probably 3 days or less, and improve our diagnostic accuracy, as well as being able to align with the current WHO CNS tumor classifications. And of course, that will be very good to supporting clinical care, improving patient outcomes, better teaching for our fellows, for our MMeds, and of course, better and more impactful research as well. So, these areas that need to be supported, infrastructure and equipment, we already talked about it, IHCs, definitely we have a few, really, and that need to be expanded. Then, of course, molecular diagnosis, which you don't have at all, that kind of be thought about as well. Training and mentorship, definitely, for both the teachers and the students, as well as improving research collaborations as well. This one I already talked about it. Of course, IHC Stainer, which is automated digital slide scanner. We have one, but it's a bit old and really frequently breaks down. Yet this is very, very important in teaching of residents. So one of the gaps that we have, like I told you, is that we don't have a subspecialization in our department. And one of the things would need to specialize in is neuropathology. We don't have a neuropathologists in Uganda. I think there are very few around the East Africa, and very few general around sub-Saharan Africa in that case. So that's a big gap, and because of that, that may limit the kind of diagnosis that are done and the kind of accuracy, diagnostic accuracy and achievement that we are doing. Of course, that may be helped by short-term observerships or even fellowships. Fellowships in neuropathology, the way there is a fellowship in neurosurgery, and continuous professional development, and of course conferences like this may be able to improve our knowledge and of course ultimately skills. And of course, usually with pathology, you cannot really forget the lab technologist. Usually, as much as they work on other samples, they bring samples a bit very unique, special, and a little bit very precious. So they may need more upskilling in that area. Of course, research is very key. Research may bring in funds, research may bring in visibility, and there are very many things that you can do in research. And of course, with really support, that with very good support, you'll have definitely improved patient outcomes, better tumor classification, training programs, MEDs, neurosurgery, fellowship neurosurgery are going to improve. And of course, this could be really one of the biggest diagnostic hubs as well. Specialization is very key, like I told you before. And of course, the engagement in research and grants. One of the ways you can be funded, of course, is by getting equipment donations. The way I've donated to neurosurgery, I see textbooks and other equipment that Dr. Blessing talked about, that can also apply to pathology. Some of these are very, very expensive machines. So instead of giving money, you'd actually donate. If you had a refurbished one, maybe in the US, or a new one, ultimately. Capacity building grants, joint research funding. These ones, the joint research fundings are definitely a little bit smaller. Capacity building grants a bit much bigger. They look at health systems and staffing. Those are very key. As well as joint research funding, where you, of course, have collaborators like those from University of Colorado and coming together to really pull a few funds so that research is done. Thank you very much for listening.
Someone around? But for the next session, we are going to have the question and answer session now, and I will call upon the first three presenters to resume your seats in front here, and we shall entertain questions from the audience. But before that, I want to recognize a few companies that are here this morning. We have Veram Healthcare, who are dealers in Neurocap and Surgeware. We have Philips Pharmaceuticals Uganda Limited, who are partners with Ethcon and Johnson & Johnson for sutures. We have Apex Pharmaceuticals, which is under Philips Pharmaceuticals, and these mainly deal in Somazina, Citicolin, Nucleo CMP40, and Gamalet B6. We also have Acelia Life Sciences in the other corner, and these deal mainly in Citicolin sodium, both tablets and injections. And they also have WEN60, which is enoxaparin. We have Tulsi Pharmaceuticals, who are the main suppliers of Cerebral Heal and Lacosa. We also have MSN, who are the suppliers of Pregasafe ER, Welltech Neuro, Welltech Omega, and Cosamide. You're welcome. So let's have the question and answer session, and everybody is free to ask wherever they wish or on whatever they feel they did not understand well, or also give a vote of thanks and appreciation for the presenters where possible. Thank you very much. Questions are very welcome now. Yes, Dr. Blessing.
Okay, thank you to all our presenters. I have a question for Professor Lilhei. The watch and wait approach towards vestibular schwannomas. What are the classic candidates that usually apply this to? And does it alter when it is syndromic patients, let's say patients with neurofibromatosis or other neurocutaneous disorders? Then a question to Professor Ormond. The WADA test, the lateralization of eloquent cortex, especially when you're doing white matter dissection and intrinsic tumors. Does the old WADA test or the AMITO test still hold a place in current practice in your area with the current advances in functional neuroimaging and the rest? Dr. Raymond, thank you so much for being a good friend to neurosurgery and also for coming, and we always disturb you with our specimens. Are you able to perform frozen sections in your current status, or do you have some plans in that? I know you have work in progress in getting all these other equipment and reagents to help us to improve the quality of tests. And the third one is, are you interested in becoming a neuropathologist as well, or at least some of your trainees to help boost your department? Okay.
Okay. So I think what you shall do, you will note down the questions, then we shall answer them at once.
Thank you very much for those eloquent presentations. I would. My questions are directed to Professor Hammond about localization and mapping of brain, early localization and mapping of brain. I didn't hear the names I know. Brodmann, for example, Brokers, where does it leave them? And then Wanike, Brodmann, Brokers. I didn't hear them. Where does it leave them? and then Dr. Raymond, I thank you very much for pioneering actually neurosurgical services in our institution in the region. And I understand when your complaints about small volumes of specimens. But you see, between you and us, for us who are middlemen, there are other people who allow us to do the surgery, to give the specimens. And in that regard, I think we also have, we are also complaining that we are having very limited opportunities to operate these patients. So we can only pass to you what we have harvested from the patients, and I think there's a very big bottleneck in achieving these specimens. And about dividing specimens, yes, I do understand. Thank you.
Thank you very much, Professor. I think we are going to first listen in from our presenters for the first set of questions.
In the past, when I was training in Makere, there was what they call tumor print, and it used to be very useful in diagnosing lymphomas. At that time when I was training, Buck's lymphoma was at its peak, and you needed to diagnose it very quickly. So we used to to do tumor prints. I don't know whether you do tumor prints also in your institution. And if you don't do, why don't you do tumor prints?
Okay, so let's start with Dr. Raymond Atwine.
Yeah, thank you very much, Dr. Blessing and Professor Chitia. I think one of the questions you asked is going to be an answer to one of the questions that Dr. Blessing asked. That is a question that was related to frozen sections. Currently, we don't have the resources to do frozen section, the way we don't have resources to do molecular. But one of the alternatives to that is imprint cytology. Imprint cytology is a very big alternative to frozen section. So that is one of the things that we can sit on table and see how we can really do it, because that would be really very much easier to do and of course really cost effective. You get the tumor, you imprint it on the slide, I take it to the lab, I'll give you back results within probably 10 minutes or 20 minutes. And for lymphoma, definitely that would be a game changer. You'll probably abort the surgery or something like that. So that would be a very big alternative, and that one we do. That one just needs a collaboration between the neurosurgical team and the pathology team, but that one will definitely be able to do 100%. About my intent in becoming a neuropathologist, actually currently I'm doing a fellowship that is looking at dementia. And one of the things that in my fellowship that I'm supposed to do, I'm supposed to actually do autopsies to see the magnitude of dementia in our elderly population. So I already expressed the interest, and definitely what I need is what I lack is the skills. But definitely I'm already doing it under my current fellowship. So I just need the skilling, but the interest is already there 100%. Yeah, I think those are. But thank you very much for answering the question about the low volumes. I think I know with improved support from the surgery side, we shall definitely get more samples when you operate more patients. So that was really well answered. Thank you very much, Professor Chitia. I think that's it from me. Thank you.
All right. Couple questions. Maybe I'll stand like like Dr. Raymond did. Pardon me. So, two questions. One was about what we typically use nowadays to localize dominance, right? Which hemisphere is dominant? Functional MRI is the most common, and we would only resort to other tests, more invasive studies like you're describing, if we can't get it from a functional MRI. So functional MRI usually is quite good at determining dominance, left versus right, and it's non-invasive and much lower risk. So typically, in my practice, I rely on functional MRI. I think Dr. Lilhai is the same. That's most common how we would determine dominance. And then Professor Kitje asks about why my lecture didn't mention Broca and Wernicke's areas and various Brodmann areas. So what we've did, a couple things. One is modern neuroanatomists don't like eponyms and have really tried to shy away from eponyms. And histologic areas, right, which is what Brodmann's areas are, which are determined by different cell types in different areas of the brain, don't always completely correlate with function. And most of our functional understanding is built now on MR connectivity maps and white matter pathways, and cortical and subcortical mapping pathways. And when you put those all together, we still often teach at the basic neuroscience level. Wernicke and Broca, right, with the arcuate vesiculus is like the standard language pathways, but it's oversimplified and not terribly accurate beyond just understanding there's a semantic and a phonemic aspect to speech pathways. So my focus here was trying to get to, kind of a quick history, because we had 20 minutes to get to Aristotle to our modern view and how that led to cortical and subcortical mapping for safety. There is some variability from one patient to another, and that's an important point that was discovered first by Wilder Penfield and described in his paper, that there is some variability from patient to patient, and that again emphasizes the importance of not making assumptions and mapping the patient during surgery to really truly map out these pathways. Gliomas can also shift pathways, either from mass effect and invasion in different ways from one patient to another, and that can vary by pathology. So we don't necessarily rely on broken Wernicke alone, but instead we follow the more modern, more complex pathways, but also acknowledge there's some patient-to-patient variability that's important to test out during surgery.
So I think Dr. Blessing's question for me was really a two-part question. One, if you choose to follow these tumors conservatively or with observation, just the routine that I tend to use is initially MRI scan definitely, because it tends to be much more sensitive than CT, but MRI scan 6 months after the original MRI scan, maybe once again in 6 months. If no change, then I go to yearly scans, and then to every 2-3 years. So gradually wean out those scans over a period of years, but initially every 6 months for a year or year and a half. You brought up the issue of NF2. NF2 is a real dilemma if you have bilateral vestibular schwannomas. And there's no right answer to how you treat these. Usually patients with vestibular schwannomas that are bilateral will present with hearing loss or very poor hearing on one side and preserved hearing on the other. The last thing you want to do is cause them to become deaf. Sometimes that's unavoidable, but you'd like to push that off as long as you can. So strategies for treatment are the big tumor, if it's growing, and they're usually deaf on that side, surgery. Observation on the side that has intact hearing. In a patient that has intact hearing bilaterally, certainly a strategy is to try to do a hearing preservation surgery on the smaller tumor. If you're successful, then the other tumor you can treat either with radiosurgery or surgery itself. We do a fair number of cochlear implants now from our Neuro-Otology team, and that's become for an eventual treatment for patients with bilateral vestibular schwannomas. And sometimes now Dr. Gubbles, who's our neuro-otologist, will actually do the implant at the time of the surgery. So not a separate operation. So I think I answered it? Okay, thank you.
Yes, thank you very much. Do we have any other questions? Yes, I can see one at the back.
Yes, good morning, professors, our visiting professors, and our professors and lecturers here at Mbara. Ndege Moses. I just completed my program at Makerere University. Sorry I came a bit late. I'm happy to have been part of the sessions. Firstly, I would like to appreciate you for this intense program. It's a benefit for some of us. We have an opportunity to be exposed to the science in neurosurgical care, in neurosurgical oncology care in your centers. And it's pleasing that Mbara University and Mbara Regional Referral Hospital have taken the initiative to spearhead this wonderful initiative. Thank you very much. The interdisciplinary nature of this discussion is also very wonderful, and it needs to be applauded. I have a few questions to the presenter. I will specifically start with
Prof. That is Dr. Ryan. I wanted to inquire, are there any ongoing researches to cater for preservation of white fibers in glioma surgery in low settings like ours where we don't have access to intraoperative MRIs? I'd want to know whether there are any ongoing researches to help us and see that we can preserve our patients' functional abilities postoperatively. I saw one of the cases which was recorded in your notes, and you did a 50% resection in order to preserve the white matter. So I wanted to know how we can be helped so that we also are able to determine when to stop the surgery so that we can preserve the patient's clinical outlook postoperatively. I also have a question for Dr. Raymond. Thank you for detailed discussion on the histology and those other sections that are very relevant for neuro-oncology. I however want to inquire whether you said you had some limitations in your performance of work. I wanted to know whether you do some of these things in your reports, whether you were able to identify microvascular density, whether you're able to identify those, whether you report them, because I think that can also be telling in the nature of mass and maybe how aggressive it is, whether you give such comments, whether you do MVD, whether you also determine the mitotic indices for the brain tumors, whether you're also able to necrosis. I'm sure you usually report on that, but I wanted to inquire on these two specifically, microvascular density and mitotic indices for these brain tumors. Thank you very much, Doc.
Any other questions? Okay, if not, let's have answers for the first two questions.
Yeah, thank you very much. I think you're my former student, but thank you very much for the question. Yeah, of course, we really do an extensive morphologic description and diagnosis based on the morphology. And of course, like you are very well aware, is that the tumor grading is really very key. And the tumor grading may be determined by very many things, but one of which is Chi-60 mitotic index. And this mitotic index can be seen in morphology, where we are able to manually count the mitosis in the tumor, which we definitely do, per high power field or per 10 high power field. So that one will definitely report in the reports. And on that, to supplement with that, you'll definitely be able to do a Chi-67, which may probably be more accurate than your manual counting as well. So that one is done. About the microvascular proliferation, that one is also, of course, commented on in our reports very well with ease. Yeah, so that one we do, as well as necrosis and other things. That would tilt a tumor from a low grade to a high grade. So those ones on morphology you'll definitely be able to do. So on morphology, you'll be able to definitely differentiate between a low grade and high grade. Then with further HCs, you can be able to subtype. For the moleculars, the presentation I gave was looking at the molecular surrogates with IHC. You understand? Such as P53. When we do P53 IHC, it's a surrogate for P53 mutation. Not actually showing that there's a P53 mutation, but it's a surrogate for P53 mutation in that case, as well as ATRX2 and then the other ones. So that one we can do. We can tell this is a surrogate, and then based on the interpretation, the clinician or the pathologist can come up with the diagnosis in that case. But for the actual molecular, like I told you, diagnostics, we don't have them in-house. And I think that is a big problem for the low to middle income countries as well. Thank you very much.
So your question, I think, is very appropriate. We hear all these things that can be done in certain places, but not here. So then what can we do here to make a difference for the safety and efficacy of surgery in the setting of gliomas? But what I would like to emphasize is that a couple things. One, functional MRI obviously is challenging, but an intraoperative MRI is really out of reach. But studies that have looked at intraoperative ultrasound versus intraoperative MRI in the hands of an experienced sonographer, that similar extent of resection is possible with a lower time of surgery and also lower risk of infection to use ultrasound instead of intraoperative MRI. So we have intraoperative ultrasound here. There is a steep learning curve to learn how to use it well and interpret the images properly, but we'll get into that in the next part of this morning's session. We'll talk about intraoperative ultrasound, and you'll see that for glioma resection, it's very useful. It can help with understanding anatomy, even after brain shift, determining what's tumor, what's not tumor. And the nice thing about cortical and subcortical mapping is if you can help over time develop the expertise in a local institution, the consumables necessary are much less expensive than some of these other modalities that we're talking about. And so there are centers in low and middle income countries that do mapping during surgery. So that is also not completely out of reach to bring to Mbarara or to Kampala. I know Moy, for example, Moy does have some, they have motor evoked potentials and somatosensory evoked potentials that can be performed locally for spine surgery, but that can be useful in brain surgery as well. And if you have that technology and those consumables transitioning over to cortical mapping of the brain, it's the same software, same consumables. It's just a slightly different learning set of talent and skills for the neuromonitoring people. So I think that's within reach as well in the near future. But today we'll talk about ultrasound, which is very good. I think you want to say something?
So I'd like to kind of present a little controversy with people. So the histology does very well, I think, in differentiating gliomas from other tumors most of the time. And to be very honest, what do we have for treatment for high-grade gliomas? Right now, we've got radiation and we've got temozolomide. Do the mutations actually help? Well, they do help with prognosis, but they actually don't figure in to our treatment very greatly. I think the one exception to that is a low-grade glioma, and the IDH1 mutation now has become very important because we've got some of the IDH inhibitors that we can forego radiation and chemotherapy. But to be honest, for the high-grade gliomas, doing all of the fancy studies isn't changing a lot of what we do, even in the U.S. It's prognostic, but does it determine treatment? Rarely. So, just in defense, I think that what we've got is probably pretty good.
For the diffuse gliomas.
Yes, for the diffuse high grade.
Yes, thank you very much. There is a group of members that we did not introduce, and I think Professor Kevin will introduce them at this point. You notice we introduced each and everybody apart from your team. I think it will be better you introduce them as we go into the next set of sessions. The team that you came with.
Right, I think maybe I'll allow them to introduce themselves. So.
I'm Ryan. I'm the Brain Tumor Fellow in Colorado. It's nice to meet everybody. Thank you very much for having me. It's been a pleasure.
I'm Nicole. I'm one of the ICU nurses on the Neuro ICU. Hi, my name's Marissa. I'm one of the physician assistants in the Neurosurgical ICU at Colorado. This is my second year coming back. It's great to see a lot of familiar faces, so thank you so much for having us.
Yes, so we are going to have the next session, which is the hands-on practice for cranial ultrasound scan. And Professor Ryan is going to take us through this session. Thereafter, we shall have a working tea as we try to wind up to catch up with the other activities that will happen at the hospital. Professor Ryan, you're welcome.
All right. So we're going to talk about cranial and a little bit of spinal pathology on ultrasound and how it's useful intraoperatively. From a brain tumor perspective, ultrasound's useful really at every step of the procedure. Prior to durotomy, it helps to assess whether the target lesion is centered in the craniotomy. Very important when we don't have neuronavigation, especially like here in Barora. If a safe extension of the craniotomy, should you perform that prior to dural opening, now you can know before you open the dura. You don't have to find the tumor and then realize in retrospect it would have been better to have a larger craniotomy or a different location of the craniotomy. After dural opening, by release of CSF or brain swelling, you can get significant brain shift. This changes surgical anatomy from preoperative imaging and really makes navigation systems now inaccurate. An ultrasound there can be used to help identify the targeted lesion, important landmarks close by, and reset shift to understand tumor localization in relation to surrounding structures. Provides information regarding which gyrus is infiltrated, which might be spared, and it provides real-time information. So when in doubt, it provides more reliable information than neuronavigation, which is based on preoperative imaging. If you have marked brain swelling due to large tumors with cystic components, you can actually then perform cyst puncture during the operation. You can assess for hematoma if you suddenly get brain swelling or hydrocephalus. You can use it to guide passage of ventricular catheters before removal of the solid tumor mass. If you're going after a deep-seated lesion, you can use ultrasound to help plan a trajectory to find the lesion prior to corticectomy. During the course of surgery, periodic use of the ultrasound helps you to adapt to surgically induced changes of the tumor or the brain surface that can help you not lose track of what's tumor and what's not tumor on the image. It also helps you to assess for residual tumor. And, you do get artifact on ultrasound from blood products, local brain contusion that reduces its specificity, and you can get false positive findings. How you can avoid that is frequent use of the ultrasound over the course of the same procedure and frequent use of the ultrasound in general, so you understand what those artifacts are. Here's an example. You place the ultrasound over the craniotomy site, and maybe you start like this. You've opened the craniotomy here, and you see the edge of the tumor, but you missed the tumor. Now you can enlarge the craniotomy. If you have a deep-seated lesion on this side, you now can identify this sulcus is just an example. You go down this sulcus, and you're right above the tumor, so there's less white matter to traverse, so you can help plan trajectories in real time. There are three different, and this shows four, but there are no 3D ultrasound probes for neurosurgery yet, although they are in development. But really, we think about phased array probes or sector array probes. That's in your upper right, which is like a burr probe. So it's a small footprint probe that makes a triangular image, so you see a larger area of the underlying tissue than the probe tip itself. This is useful for, again, smaller craniotomies or smaller access points, but a linear probe gives you the best quality image. A curved array transducer or a convex probe gives you a larger field of view. That's certainly a better image than the burr probe, but not as high a resolution as the linear probe. This is an example of tumor resection. On the left is before the resection on ultrasound, after is post-resection. It also shows one of the very common artifacts, which is when you fill your cavity with fluid. Excuse me, because the ultrasound waves going through fluid are not attenuated very much. So through fluid, the back wall of the fluid cavity appears brighter. So you can see this straight line of brighter tissue. This is the cerebellum here. This is the falx. But you see the tissue is darker here. That doesn't mean that this is pathologic. It's just looking at ultrasound through the fluid makes the back wall brighter. And that's a normal artifact. Echogenicity of an intracranial tumor is dependent on cell density, so higher density means greater echogenicity, so higher grade tumors that are more dense tend to be brighter. On ultrasound, that's true except in areas of necrosis, which are then darker because they have a lower cell density. Low-grade gliomas differentiation of the border of the lesion then becomes more challenging because vasogenic or cytotoxic edema also increase the echogenicity of the white matter, sometimes in a very similar fashion to the low-grade glioma. And that effect is more pronounced if you have a sector or curved array transducers versus a linear array probe, because the linear array probe, with more ultrasound waves going in a straight line and bouncing back to the transducer, you get higher resolution, and so you also have better contrast between structures. So often it's best to do a lot of your adjustments on the ultrasound machine before you ever open the dura to make sure you have a good picture. And based on image settings and depth of the lesion, contrast, focus, other imaging settings can be optimized before you operate and create artifact inside the brain tissue that obscures visualization and makes it harder to understand tumor versus non-tumor. And the contrast between normal brain tissue and tumor is higher, again, if you use a linear array transducer. This is just a quick image showing basic echogenicity of different structures in the brain, where the meninges are quite reflective and are bright. Scar tissue also tends to be quite bright, areas of gliosis. Necrosis can be quite variable depending on how necrotic something is versus fibrotic. Tumor tends to be, again, bright. Normal cortical tissue is brighter than white matter, so gray matter is brighter than white matter, except if you have a setting of vasogenic or cytotoxic edema, which brightens the white matter. So if you look at it and the cortex looks darker than the white matter, you know the white matter is edematous or gliotic, right? There's or has tumor in it. This is a high-grade glioma, so you see that it's quite bright around the areas of higher cellular density. This tends to be areas that are contrast enhancing on MRI. Areas of central necrosis are then dark, and then because it's diffusely infiltrating, the border is a little hazy and obscure and fades toward what is normal then, white matter here. This is an example of a low-grade glioma. There's in two different slices through the same patient, where you can see there's a little more formal demarcation from tumor versus non-tumor. but it's a little more homogeneous than the high-grade glioma and tends to not be as bright. This is a pediatric case showing hemorrhage, intraventricular hemorrhage. So you can see a fluid level here, and you can appreciate this is acute. As blood turns more chronic, it turns darker on ultrasound. This is an example of reverberation artifacts. You see these striped lines going through the tissue. That's not anatomic. It's also not pathologic. It's the nature of some objects are so dense, like if you have metal, for example, that often causes reverberation artifact. So you get lines of that object across the tissue because it bounces the sound waves through the tissue. So things to just be aware of. This is that image again, so you see that attenuation difference, which we showed when you go through fluid, how to avoid that. If you see that and it's confusing whether there's tumor at the border or not, if you have a large enough craniotomy, you can actually put the transducer on the brain instead of through the fluid. And now you can look where your ultrasound waves go just through tissue, and then you can better demarcate tumor versus non-tumor at the border without that bright artifact through the fluid. Vascular imaging, we can talk about the Doppler effect. It's a physics phenomenon where a radio frequency wave vibrates at a specific frequency, and it changes its vibration rate when reflecting on a moving surface, and it's proportional to the velocity of blood. It's also proportional to the incidence angle, so you need to try to be as parallel to the blood vessel as possible if you're looking for velocity measurements on Doppler, which generally is about 60 degrees is what you try to get down to if you're trying to get accurate velocity measurements. But Doppler can be very useful even if you're just using color Doppler to help you see the vascularity of the tumor, where the B-mode ultrasound is just this bright ball of tumor, but you see it's very vascular when we add the Doppler image. This is a meningioma here on the right, where you can see a patent superior sagittal sinus along the falx. This is overlaid, an ultrasound overlaid on MRI, but you can actually see lenticulostriate arteries here on the Doppler image to help you better assess, make sure you don't get too close to the lenticulostriate arteries and insular resection. This is another example of artifact. This is a piece of gel foam, and you can see a piece of gel foam completely blocks the signal behind it completely, so ultrasound waves don't pass through the gel foam. This can be useful if you have a very small piece. It can be a bright beacon along your trajectory path to help you see. So let's say if I'm here and I want to get to a tumor that's here, and I'm partway in, I can leave a small piece of gel foam there that's very bright, but if it's small enough, it won't create a significant artifact to where I can see where I am on my path into the lesion. So just because this creates significant artifact doesn't mean it cannot be useful to you also, but you just need to be aware that things like Surgicel, most hemostatic agents block ultrasound signal, and so they should be avoided really until you're done with your control images. And this is an example of attenuation that happens with, this is just a piece of cotton here, like a cottonoid, and you see that here it's brighter past the fluid, right? Here it's brighter past the fluid, and now where the cotton is in the cavity, now it's attenuated behind that signal about to what the normal brain would look like. So you have to be careful. You might interpret this as residual tumor, but it's not. You've just attenuated some of the signal through the fluid. There's a few more pathologies we'll show here. This is a brain metastasis, pre and post resection. This is the surrounding vasogenic edema. This is a Chiari decompression where you can see the dura. This is the cerebellar tonsils. This is the brainstem. And there's a cyst within the spinal cord at the point of compression. This is a shunt patient. This is a coronal ultrasound where you can see large ventricles. This is after removal of the stylet you can still see the tip of the catheter because of the side holes reflect a lot of ultrasound images, and you can see the pathway through the white matter that creates this echogenic signal. But this is a video showing us passing this catheter under direct, so this is direct ultrasound guided placement of a ventricular catheter, where you actually can watch the catheter go directly into the foramen of Monroe. It's useful in other pathologies. This is an early abscess, so a brain abscess. It hasn't developed a wall distinctively yet, but there's significant vasogenic edema surrounding this abscess. And this is what soft pus looks like if you see this darker material. This is just a Doppler image on a colon cancer metastasis in the brain with surrounding vasogenic edema. The ventricles are here below, and the falx is here at midline. You see how bright the meninges are. This is an infiltrative glioma that starts here on the left and crosses the corpus callosum. Normally the corpus callosum is quite dark on ultrasound because it has dense white matter with myelin, but when you get the infiltration of the glioma, it's bright and thickened in comparison to normal. This is a cavernous malformation, which you can appreciate with these grape-like bundles. This is then a normal brain. Just to give an example of what normal brain looks like, where the gray matter is again brighter than the white matter here, and the signal attenuates just based on distance, so that on the contralateral hemisphere you don't see much detail, but on the ipsilateral hemisphere you can see a lot of detail. And this just is a video scrolling through what a normal coronal brain looks like from a parietal approach. This is now showing the challenges of recurrence after radiation. So you radiate the brain, the whole thing becomes gliotic, and it can become very difficult to now determine what's tumor and what's not tumor on ultrasound. So radiation does create additional challenges. This is a spine case presentation, just to give you an example where this is useful in the spine, and it's not just in tumor pathology, but similar to the brain, it's also useful in infectious or degenerative pathology. This is a patient who had a 4-year symptom progression of cervical myelopathy, who was found to have this mass on MRI consistent with a meningioma. And you can see on ultrasound after opening, you can make sure before you ever open dura that you're at the right level, that the entire tumor is included in your exposure. And this is the ultrasound image of the normal spinal cord. This is the dura. This is the lesion on sagittal view, and this is on axial view. And you see the spinal cord pushed here to the side. This is now post-resection, so the spinal cord is now in a normal position. The dura is not yet closed, but the spinal cord is well decompressed and back on the axial in a more midline position. This is a sagittal view of an epidural abscess, and in this case you see the posterior dura, the spinal cord with CSF around it, and this is the ventral dura, this line here, and then there's this echogenic expansile lesion anterior to the PLL, and this was an abscess that can then be evacuated, and then you can assess the success of your evacuation by bringing the ultrasound in and making sure that the cord is well decompressed. In summary, the key to successful intraoperative ultrasound involves learning the use of the ultrasound machine to be able to adjust things like frequency, power, and focus, understand basic ultrasound anatomy of the brain or other structures, the spine, peripheral nerves. I recommend using standardized approaches. So if you think of a pterional approach, you can get a good axial and a coronal view. You cannot get a good parietal view. You can get a lot of oblique views, but to better understand what you're looking at, it's best to select those orthogonal views first and really look at the axial, look at the coronal views well, understand the anatomy surrounding structures, and then you can do the oblique to see the full extent of the pathology. Understand how pathology affects echogenicity of various structures are important, and that mostly involves frequency of use. So if you use ultrasound frequently, you're going to get better over time at what you're looking at. Understand common artifacts leading to misinterpretation of imaging characteristics. I find that the best way to do that is to image frequently over the course of a procedure so you can see how artifacts creep in over the course of the resection. With practice, ultrasound can greatly enhance cranial or other neurosurgery. As I've shown you some spine cases there, lesion localization, extent of resection, catheter placement, abscess aspiration, needle biopsy, etc., adequacy of craniotomy or spinal exposure, etc. Thank you very much. So that was a quick overview. I do have a handheld ultrasound machine here for those who are interested in coming and doing some hands-on approaches before we're in the operating theaters, where we can talk about some of these functions and how to use them. And for vascular imaging, we can use, if we have a volunteer who wants to show us their carotid, we can do that. And I brought a spine model with me, but it'll take just a few minutes to set up. Maybe first we can ask if there's questions about this discussion before we get the hands-on. No? All right.
Thank you very much, Professor.
Thank you, Professor, so much for the presentation. And I think things are going to the fellows and the trainees and the rest of the faculty. What Professor Omond has just basically presented is what is going to demonstrate, and things are going to get clearer. Like he said, it's a steep learning curve. You might get a little bit of challenges grasping the concepts in the initial period, but with more hands-on, it's going to be getting more clearer. And once we go to theater and he exactly demonstrates what he has been doing here again, things will make more sense for us. Our surgeries are supposed to be starting at around 11 o'clock, so we're just a little bit having a few minutes so to head out. So in the interest of time, we will combine the tea break as he's demonstrating. People can have like a working tea, so that after demonstration we can straight away head to the hospital. In a special way, I want to thank Dr. Senyonjo. Dr. Senyonjo is an anesthesiologist. He's very interested in use of ultrasound. He's traveled all the way from Kampala, so he's going to be with us for the entire time. He's interested so much in ultrasound use, so he'll be able to interact. Dr. Ntege Dr. Ntege Joseph and Dr. Ntege, you're most welcome. These are the youngest neurosurgeons that we've graduated so far. You're most welcome. Dr. Ntege Joseph is working at Entebbe, and Dr. Ntege is at Mulago as well. So you're most welcome, doctors. Thank you. All right, so I think we can set up for the demonstration. We can have some volunteers, the trainees. We can come and volunteer here. And also, I also want to thank, they had already mentioned it, our partners, the pharma. They've already mentioned all of your names. So Achelia, they provide a lot of our drugs that we use. Tulsi Pharmaceuticals, Mr. Arun, and then Viram Pharma. These supply us with the shunts, the Shabra shunts that we use, and the other cranioplastic kits. So thank you so much for coming around and also demonstrating your products.
Yes, thank you very much, Dr. Blessing. So at this juncture, we are going to have a working tea. We shall have Professor Kicha and Dr. Blessing, together with the Colorado University team, breakfast, and then the rest of us shall follow in line. Meanwhile, like we have been requested, let's have one volunteer who is going to help out. Yes, so I've been informed that we may need to wait for at least 2 more minutes. In the meantime, for those who have just joined in, this is the 3rd International Neurosurgery Conference under the theme Advancements in Neurosurgical Oncology and Neurocritical Care, Pioneering Innovations for Enhanced Patient Outcomes. So for those online, in case of any questions, we shall read them out here and you obviously get the answers to those questions. So for the rest of the members, we can be heading out to get our tea. I've been informed for the guests, theirs will be ready within 2 minutes. So the rest of us, we can be heading out. Meanwhile, as we also prepare for the hands-on ultrasound scan session. Thank you.
Also an extra axial tumor there on the right side of the screen, causing a small amount of compression. It just abuts the cord there. See how it's not present on the left side of the screen, but it's present on the right? Okay. So if people want to come and look at this is then a sagittal view of the spinal cord. You can see the dura, the spinal cord, and then the ventral spinal elements, which the bone is right there, and then there's a little depression for the disc space there. All right. You want to try this out? So we can do that, yeah, to look at your carotid. We can turn on vascular imaging. Yep. So here's the gel.
Let me remove this first.
I'll turn on the vascular setting. We could also just... All right, so... So we'll turn on color Doppler. And see what we can find here. That's your jugular vein right there.
Mm-hmm.
See this?
Yeah, that's one. Yeah, huge one up.
Where did Marissa go? Trying to remember how to turn on. Sorry, yeah, people want to hear me. So this is the color Doppler on the external carotid here. And if we turn on the pulse wave, there you can see the arterial waveform of the carotid artery. Okay. So that's something we can do with our machines in the OR today as well. So you can see the vessels, intracranial vessels. So these handheld devices are nice because they're less expensive and they're portable, but they also get hot quickly, so you only get about 10 minutes of use before you have to let them cool before you can use them again. And so they're good for demonstration purposes. They're not great for intraoperative imaging. Those are better to have bigger and a little, but pretty good quality images that you can see. Thank you. Of this? I mean, this is very useful for like point of care. So one thing so Moy has one of these, and they're using it in their ICU to learn to do TCDs, to do carotid Doppler, to do ocular ultrasound to look at optic nerve sheath diameter, and with TCDs to do resistive index to help assess intracranial pressure elevations. But they're also good for placing arterial lines or central venous lines. They can be used, like this is a spine model, so just to show that they can also be very useful for lumbar puncture, for example. If you're having a difficult case that you just can't find the lamina, then ultrasound can be useful in that setting as well. Or doing a VSAT or a paraspinal block, they're very useful in that setting too. So that's where these are useful, just something to have quick, and that's how they're really used. But this gets hot enough you can't wrap it in a sleeve, so it's not useful for an intraoperative setting. Short diagnostic or ultrasound guided procedures at the bedside, yeah. That's what it's really built for. But it's good for demonstrative purposes, like we're doing here. So, other questions?
Instead of using a CT scan guided biopsy, you can use ultrasound for spinal conditions.
Yes, you can. Not if they're bony.
No fixed bone, of course, yeah.
Yeah, if it's in the bone, then you need a CT. But if it's in the soft tissue of the lower spine, let's say, then it's useful. Ultrasound guided biopsies are great in the brain because you can watch there's an in-plane and out-of-plane view. Typically for the brain, for safety reasons, we do an in-plane view where you see the needle the entire time, or the ventricular catheter or whatever you're using to do the biopsy, and then watch it. If you have a burr hole probe, it's very useful because then you can do a small opening and in real time guide the needle down to the lesion. With the machine that you have to do a craniotomy to be able to do that, but it's still useful to get you down to a deep-seated lesion. It can be very useful to use ultrasound to guide the trajectory.
Okay.
We don't have to do that today because the tumors today are on the surface, but we do have a hydrocephalus patient that we may be able to do a demonstration on. Any other questions?
Do you have any other questions from the audience?
Use the ultrasound?
Or anyone who wants
before it overheats?
Dr. Carol, you can come and... Okay.
TCDs are harder. I mean, we can do it, but I'm not a TCD expert, so that's more Dr. Common. But we can see if we can find the internal carotid. I would use the temporal window.
So we're basically approaching, placing the probe on the temporal window.
It's typical. Here, I need to lengthen your. Yeah. Usually about 5 centimeters.
To be able to see the intracranial vessels.
Turn the beam up to. Go back to the beam mode. Yeah, but I wanted to increase the gain first. Okay. And I will turn on Doppler. And typically you find the carotid about 5 centimeters internal carotid. And the MCA, like the M1, usually about 5 centimeters from the surface. So I put the box down here. This line is a 5 centimeter line, so down here we'll see if it was sensitive enough. But you should be able to do TCDs with this.
Right.
Well, we have a little motion.
You are using the pterium as the window.
Hmm?
You are using the pterium as the window.
The temporal.
Which window are you using?
The temporal window. This one here. Temporal.
Yes, I will. Which surface marking?
Oh, on the surface, usually it's
The
deep to the
pterium.
lower than the pterium. You want
Yes.
it at the thinnest part of the bone,
Yeah. So just above, just above the pinna here.
just above this.
Yeah, above the zygoma. No. No.
No, it's too thick. The bone. It's when you gotta be as low as you can, and some people have too thick of
Yeah.
bone to see through the temporal window. And I'm not an expert on TCDs either, so.
See that?
This is color Doppler. I'm not picking up any. Oh. Sorry. Sometimes when you're first learning, like the carotid's a good one to
Okay.
just external carotid. I mean,
Right. Let's start with the external carotid. Yeah.
it's often good for- Because now there you saw the Russell. Right, there it is. And if we turn on pulse wave, move this up.
Don't have a very massive carotid. Huh? To be very patent to see.
Those vessels.
That's the red one. It's pulsating. Yeah. So just increase the gain.
Sorry. You had a pretty good view of it before, right?
Yeah.
You can zoom into it a little bit.
Yeah. Just right there. Its entirety. Get up. To myself. The carotid is very okay. That's it. Yes. Yeah. Okay. Quite easy. So with this, you can actually be able to diagnose plaques.
You can see atherosclerotic plaques with it. Yeah, you can.
And you can go local to remove the clots.
Carotids? No, I mean, if you're.
I mean, if I've got a constriction, tissue.
Yeah, then some people do carotid endarterectomy. Yes. So we'll need the tissue to clean this. Our volunteer. Thank you, sir.
So maybe we can prepare to leave for theater now, and then continue with the demonstrations in theater. So there'll be a van down waiting, and for the faculty, you'll be moving with myself and Dr. Frank. Where's Dr. Frank? Okay.
That's the battery.
Then this one you can tie it the way that I let me see if I can get it. Zoom those. Okay. couple more dollars, a zero, or zero. Thank you. Alright?